My son hurt his foot at rugby training and I was quite concerned about maybe a possible fracture or something worse. So I wanted to get it checked out quite urgently.
A patient, Amelia, had contacted her doctor with an injury for her son. The doctor reached out to us on Foxo. He did write that she was very busy. It was an urgent study for a child.
I thought that I would then have to go and make the phone calls myself to find somewhere that could fit us in to get an X-ray. And in reality, that's not how it happened at all.
Foxo comes up on our screen, it alerts us whatever we're doing. We're able to message back, ask them a question about the referral. We're able to contact our clinics and find urgent spots if it's urgent, reach out to our radiologist through Foxo to get any protocols on a referral, and then we're able to call that patient with all of that information.
Within 3 minutes, I got a call from a lady at Q-Scan. She said that my doctor had been in touch with her and she had all the information that she needed so that my son could go into a clinic and get an X-ray.
Foxo's made that booking process quick, and then when we reach out to those patients, they haven't had to wait on hold. They aren't trying to decipher a referral that they're not familiar with.
I was quite blown away with how quick the turnaround was from telling my doctor that I had big concerns about my son's injury to having my son booked in to see a radiologist at Q-Scan.
So what this means for Q-Scan is referring doctors can feel that we will book their appointments in quicker. The patients are looked after, and for Q-Scan it means repeat business. We're making patients happy, referrers happy, and we're just excited that Foxo's helped that journey for us.
Hello and welcome to day one of Radiopedia 2021 and the first of our advanced imaging sessions, which is on gynecological imaging. My name is Alexandra Stanislavski and I'm honoured and excited to be hosting this session, which features two fantastic speakers who are both renowned women's imaging radiologists here in Australia and also happen to be my personal role models. First up in this session, we have a talk on MRI of endometriosis from an expert on the subject, Natalie Yang. Next, we will hear from the wonderful Emmeline Lee about the imaging of subfertility. In the middle of the session, I will be joining Emmeline and Natalie for a quick discussion of their presentations. And then we will round up the session by showing an encore of my talk on ultrasound of ovarian masses from last year's conference. Now, hopefully, you've already noticed that we have a live chat feature. The speakers and I will be available in the live chat during the session, so if you have any questions or comment, then please drop them in there. And feel free to just say hi and let us know where you're from and how you're doing. We're also active on Twitter, and you can join the conversation there by using the hashtag Radiopedia2021. Now, day one of Radiopedia 2021 is sponsored by Foxo, and we'd like to thank them for helping to support globally affordable radiology education. Foxo presents radiology businesses integrated messaging, image and file sharing, video and MDT workspaces. Whether you're connecting with clinical and clerical teams or engaging your referral network, Foxo is a compliant, real-time solution to clinical communication. Our first lecture is by Natalie Yang, one of our conference co-conveners and the Medical Director of Radiology at the Austin Hospital in Melbourne. She will be presenting on MRI of endometriosis.
Hi, my name's Natalie Yang, and today I'll be talking about the MRI appearances of endometriosis in my talk entitled Beyond T2 Shading. As an overview, I'm going to start by touching on a little bit of the background about endometriosis. Then I'm going to talk about who should get an MRI, how that MRI should be performed, and what endometriosis can look like in its various forms on MRI. But let's start off with a little bit of background. Endometriosis is a really interesting disease. It has been described as enigmatic by some in the literature and is seen in a variety of clinical settings with a number of different clinical manifestations. It can mimic several gynecological pathologies and can be a source of great dilemma for both patient and clinician. The origins of the disease remain just as obscure, with debate over who first described it. Possibly Karl Rokitansky, who described uterine gland-containing sarcomas in ovarian tissue in 1860, or possibly surgeon Thomas Cullen, who described for the first time both the morphologic and clinical picture of a uterine adenomyoma in 1882. However, the largest body of work is really credited to this man, John Sampson. He is the one who coined the term endometriosis and was the first to postulate that the presence of endometrial cells outside of the uterus was due to tubal regurgitation and dissemination of menstrual shedding, as written in his seminal paper in 1927. Endometriosis is a disease defined as the presence of endometrial tissue outside of the uterine cavity, and it can literally occur anywhere, most commonly described in the pelvis, but can also involve areas such as around the diaphragm, in the chest, and it's even been described in the brain. It is one of the most common diseases affecting women of childbearing age, said to have a prevalence of 5 to 15%, affecting an estimated 176 million women worldwide. Patients present in a variety of ways, ranging from those that are asymptomatic to those that experience severe debilitating pelvic pain. It has an important association with infertility, with up to 50% of women with endometriosis experiencing fertility issues. The disorder represents a major cause of hysterectomy and hospitalization in the USA, with an annual societal cost estimated at almost $70 billion in 2009, with the societal cost here in Australia in the order of $7 billion per year. And it's really topical in Australia. In 2019, the Australian government revealed a $10 million commitment to a national action plan for endometriosis, with prominent lobby groups and famous celebrities opening up about their battles with the disease. And when you listen to these women, it really is heartbreaking. These women truly suffer. It's not uncommon for women to have a diagnosis that takes months, if not years, to receive a diagnosis. And there is commonly a history of multiple normal ultrasounds and visits to multiple different doctors who are not able to diagnose their condition. When it comes to the diagnosis, laparoscopy with histological confirmation remains the gold standard. And as you can see here from the laparoscopic images, endometriosis can have a number of different appearances. And so the diagnosis by visualization alone, which was relatively common practice until recently, is inaccurate for the diagnosis. Added to that, although there are a number of different classification systems for disease severity, with this, the revised classification of endometriosis published by the American Society for Reproductive Medicine in 1985, probably still the most widely used, there actually remains very little correlation between disease severity, according to the classification systems, and symptom severity. So much so that the use of these classification systems has been called into question, and the World Endometriosis Society is calling for the development of a better classification in 2017. In terms of location, I think we're all familiar with the concept that endometriosis can basically occur anywhere in the body, with the ovaries in the form of ovarian endometriomas being the most common manifestation of the disease. And it is that the term T2 shading relates to, but in all honesty, that's not the true value of MR in this setting. MRI in the right hands really comes into its own for the subtype of endometriosis known as deep infiltrating endometriosis, so-called DIE, that penetrates more than 5 millimeters under the peritoneal surface. The importance of this type of endometriosis is that it is considered a very active form of the disease and is strongly associated with pelvic pain, dyspareunia, and dyschezia. DIE has a tendency to occur in specific locations, namely the uterosacral ligaments, and a specific area called the torus uterinus, and also the posterior vaginal wall, and we will revise this anatomy later in the talk. In addition, DIE is particularly prone to involving the bowel, in particular the anterior rectal wall. And this is essentially what our endosurgical friends are particularly concerned about, because involvement here requires the addition of a colorectal surgeon to the team. The pathophysiology of this disease is fascinating. It's complex and still remains poorly understood. The most accepted theory is that of retrograde menstruation, which we have already learned was first proposed by Sampson in the 1920s. Other proposed theories include metaplastic theory, where there is differentiation of coelomic epithelial lining, the pelvic peritoneum or Müllerian remnant tissue, into functioning endometrial cells, and induction theory, where shed endometrium releases substances that induces undifferentiated mesenchyme to form endometrial tissues. Added to these theories is a complex interplay of genetic factors, immune modulation, hormonal influences, together with evidence of both lymphatic and hematological spread. So let us now ask the question, who should get an MRI? In 2017, the European Society of Urogenital Radiology published a set of guidelines for the use of MR in imaging pelvic endometriosis. These guidelines examined a series of meta-analysis and pooled the data of both ultrasound and MRI. Overall, sensitivity was higher with MR compared to ultrasound in certain areas, namely disease involving the uterosacral ligaments, the rectovaginal septum, and the vagina or posterior fornix, with comparable sensitivities and specificities for disease involving the bladder and the rectum. So, based on this data, the European guidelines recommended that transvaginal ultrasound remains the first imaging assessment for patients with suspected DIE. The role for MRI and how it appears to be used worldwide is to assist the staging and surgical planning, and is particularly useful when multiple sites of DIE are suspected. There is a reported role for those patients who have high clinical suspicion for disease, but with a negative or equivocal ultrasound result, and there is certainly a role for patients who cannot tolerate a transvaginal ultrasound. Additionally, MR can be a great problem-solving tool, and here we have a case where ultrasound identified an unusual-looking lesion in the uterine fundus, which MR confirmed to represent an accessory and cavitated uterine mass. So now let's shift our focus to how to perform the MRI. Now, I'm not one of these people who insists you must do this sequence or you must have intravaginal gel. Or I think essentially you should do whatever you need to do to get the correct answer. But if you're looking for some guidance, the European Society of Urogenital Imaging has developed some guidelines about how they think you should best perform the MR. At Austin, here in Melbourne, we scan at 1.5 Tesla, we position the patient supine, and we use phase array surface coils. We give intravenous buscopan, so in the States I think you would use glucagon, and I don't bother with gadolinium, I don't bother with intravaginal gel or rectal preparation. We did a study at my hospital that showed that you can scan the patient at whatever phase during their menstrual cycle. It really makes very little difference to the imaging. These are the sequences for your reference. Of these, the T1 fat saturated sequence is very important to increase your sensitivity for the detection of small T1 bright spots, which can help diagnose the disease, and to also try and help sort out your endometriomas. I really like a good quality T2 space. I agree that the quality is not as good as with a small volume, high resolution T2, but what it does do is it allows you to do 3D reformats and really interrogate those areas of anatomy that may harbour deep infiltrating endometriosis. At my institution, we've also played with cine loops, with Valsalva, we've tried imaging prone. To be honest, we just found that those sequences were a waste of time and of little added benefit. So with all of that, what does the disease look like on MR? And unfortunately, endometriosis doesn't present in one single way, and it really depends where it is and the type of endometriosis that you're imaging. So we're going to go through the appearances of all of these disease presentations. So let's start with our old friend, the endometrioma. We know that an endometrioma is a cystic mass arising from ectopic endometrial tissue, most typically within the ovary. The cyst wall tends to be thick and fibrotic, as we can see here in this example, and commonly has dense surrounding adhesions. And as we know, the content of the endometrioma is thick, viscous, brown, tar-like fluid, essentially old blood product from repeated cycles of hemorrhage, our so-called chocolate cyst. And it is this content that contributes to the sign known in radiology as T2 shading. For those of you who don't know, T2 is a very famous Australian tea brand here in Australia, so sorry. Anyway, so T2 shading is defined as a lesion that is T1 bright that becomes hypo-intense on the T2 weighted sequences, typically homogeneously or with evidence of layering. So let's take a look. Here we have an adnexal lesion that is bright on T1. It remains bright on the T1 fat-saturated sequence, and when we look at the T2 sequence, we can see that it is of a relatively low signal intensity or grey. And here is a different patient where we see evidence of layering. T2 shading was described by Christine Glastonbury in 2002, and at the time it was quoted that T2 shading had a sensitivity in the order of 94% with specificity in the order of 96%. However, more recent studies suggest that that specificity is more in the order of 45%, as this sign can be seen in hemorrhagic ovarian cysts and other hemorrhagic adnexal lesions. So the main differential for an endometrioma is a hemorrhagic cyst, and in truth, the distinction can be actually quite difficult. These lesions can be bright or relatively bright on the T1 fat-saturated sequences, but as you can see in this example, are typically not quite as bright as you might want to see in an endometrioma. And the T2 signal tends to be very bright, though it should be noted that endometriomas don't always have T2 shading. So in truth, the only reliable way to distinguish the two entities is to perform imaging at a 6 to 12 week time interval. And here we see the same patient imaged 4 weeks later, and you can see that the arrow is pointing to the same lesion that was seen previously, which has now become smaller, collapsed, and is in keeping with a hemorrhagic cyst. What's more specific for endometriomas rather than T2 shading is the presence of multiple bilateral T1 hyperintense cysts on T1 fat-saturated imaging, and this is regardless of what the T2 signal is. This finding is practically pathognomonic of endometriomas. Here we have an example of what's called a T2 dark spot. The presence of T2 dark spots is said to have better specificity than T2 shading and reported in the order of 93%, but with much lower sensitivity. And these images are really here to remind us that endometriomas are associated with dense adhesions and can result in an obstructive effect. This is the result of the prominent fibroblastic response seen in the disease. So here we have the so-called kissing ovaries posterior to the uterus, and in this case, we see an endometrioma that results in ureteric obstruction. It is really well documented in the literature that women with endometriosis are at increased risk of developing both clear cell and endometrioid subtype of epithelial ovarian carcinoma. The rate is quoted in the literature at about 2.5%. And so here, after more than 10 years of practice and hundreds of MRIs later, this is my first case. So what you see in this case is the ovary is really large, and there are a number of papillary type projections, particularly in the posterior aspect of the disease. We called this patient back to give contrast, and we show that those papillary projections enhance, and this lesion has come back as endometrioid carcinoma. So endometriosis is a common cause of fallopian tube dilatation, along with pelvic inflammatory disease, which we know in the chronic form presents with hydrosalpinx. If, however, you see T1 hyperintense content within a dilated fallopian tube, like in this instance, it's called hematosalpinx, and this is very specific for endometriosis, even if there are no other features of endometriosis elsewhere within the pelvis, and even if the T2 signal remains relatively bright without evidence of T2 shading. At laparoscopy, about 30% of women with endometriosis have an associated tubal abnormality, most typically due to serosal deposits that lead to peritubal adhesions and subsequent tubal obstruction. So, uterosacral ligament involvement and torus uterine endometriosis. Endometriosis involving both of these structures is classified as deep infiltrating endometriosis. MR has a reported sensitivity of 69% and specificity of greater than 90% for the diagnosis of endometriosis in this location. Deep infiltrating endometriosis, unlike our friend the endometrioma, is characterized by the presence of dense fibrous tissue, smooth muscle with embedded ectopic endometrial glands and stromal cells. And as a result, these lesions can be very easily overlooked at MR, as they have low T2 signal and are commonly located next to structures which have normal T2 hypointensity within. And these lesions are less likely to contain high T1 signal intensity. So they're actually really quite a different presentation of endometriosis as compared to the ovarian endometrioma, which we've just seen. So before we get into a broader discussion, what are the uterosacral ligaments? And look, you can easily bamboozle both radiologists and clinicians by pulling this sort of terminology out, because no one really knows what you're talking about. So let's revise the anatomy. So here I have for you a laparoscopic image of the pelvis. So we're located within the pouch of Douglas with insufflation. So the uterus is reflected superiorly at the top of the image, and the rectum is at the bottom, inferior portion of the image. On the left side of the image, we have the fallopian tube indicated, as well as the ovary there in white. And the uterosacral ligaments are those structures indicated by the green arrows. So the uterosacral ligaments are these bands of dense fibrous tissue which attach the cervix to the sacrum. In surgical series, these structures measure about 12 to 13 centimetres and can be anatomically divided into 3 sections. The cervical section, or the so-called torus uterinus, is the portion that blends with the cardinal ligaments at the back of the uterus as it comes towards the midline. The intermediate sections, which is best seen under surgical tension, and then the proximal sections, which are relatively thin with a diffuse attachment to the sacrum. These structures contain fatty tissue, fibrous strands, and nerves destined for the cervix and the vagina. And it's why endometriosis in this location is very commonly very symptomatic for patients. So how do you find those structures on an MRI? So I'm going to take you through my tips for finding it. It's taken me many years, to be honest, to actually confidently identify these structures. And for a time there, I was incorrectly labeling the top of the vagina as uterosacral ligaments. So just really practice on as many female pelvic MRs you can get. As I said to you, I like the 3D space because you can use it to reformat in different planes and really allows you to really try and understand this anatomy, which can sometimes be distorted depending on what disease there is or if the uterus sits in a funny location. So these are my tips for how you find the torus uterinus and the uterosacral ligaments. So the first thing I do is I start in the midline sagittal plane and identify the cervix and the internal os. So that's a really key landmark, the internal os, for the identification of the torus uterinus. So find the internal os and head posteriorly, and where you hit the edge of the cervix, that's where the torus uterinus is. You then, in that sagittal plane, want to then sort of scroll laterally in the sagittal plane toward the pelvic side wall, and that will help you trace the uterosacral ligament in that sagittal plane. You then correlate that on the axial image, and as I said to you, just reconfirm to yourself that you are not looking at the collapsed vagina. So often what I'll do is I'll start at the perineum and work upwards and follow the vagina and understand where that ends before then identifying where the internal os is to then identify the uterosacral ligaments. When the anatomy is extremely distorted with really severe endometriosis, to be honest, it can be really hard to find those structures. So let's step through that process together. So here we have sagittal T2 midline view through the uterus. There's the internal os, and if we head back perpendicular posteriorly to the edge of the cervix, we then hit this band of tissue, which in this instance is abnormal, and this is the torus uterinus. We're now going to head laterally. So as we go across, we're going to follow that abnormal tissue out toward the pelvic side wall. Next, we're going to do the same patient, but now in the axial planes. In the middle there, that's the internal os. So we're going to take that and go posteriorly immediately to identify this band of abnormal stellate tissue, which is the torus uterinus. And now we're going to come down inferiorly towards the uterosacral ligament. So this thin band here, which is relatively thickened in this patient. And here again, abnormal thickened uterosacral ligaments. Now, this here is just to remind us, look for the vagina and make sure you understand where it ends, and don't call a collapsed vagina abnormal uterosacral ligaments. So that's just a bit of practice. Here we have some other cases to just drive home the teaching here. So internal os, head back, uterosacral ligaments here are bilaterally thickened, and in this instance, on the left side of the patient, there is a fleck of T1 hyperintensity. Here is the corresponding parasagittal image with this really thickened uterosacral ligament. And here is the correlative laparoscope. Isn't this beautiful? So it correlates beautifully. So you've got really thickened abnormal uterosacral ligament, that fleck of T1 hyperintense blood product, which we can see on the laparoscopic image. So that just illustrates that uterosacral ligament. Here we have another example. So internal os. Here we have the right uterosacral ligament, which is relatively thickened, black and nodular as compared to the more normal side indicated by the green arrows. And there you have the lovely laparoscopic correlation to help drive home the teaching. So involvement of the pouch of Douglas. So the pouch of Douglas is a common location for deep infiltrating endometriosis and often extends into or invades the posterior myometrium. Here we see an example of a large plaque of deep infiltrating endometriosis, essentially filling the pouch of Douglas on the sagittal imaging and resulting in that retroflexed appearance of the uterus. As is often the case in DIE, the T1 fat saturated imaging is actually relatively disappointing. It doesn't show a lot of abnormality. Here we have the same disease in the axial plane. Note the marked involvement with the rectum, with bands of adhesions extending towards the subjacent rectum. And here again, we have the beautiful correlation of the laparoscopic imaging, just demonstrating that what we see on MR is quite reproducible with respect to laparoscopy. There is this special subtype of endometriosis, which is called solid invasive endometriosis. It's confusing because a lot of our gynecological colleagues erroneously call this disease posterior adenomyosis. So the first time I saw the request for posterior adenomyosis, I had no idea what the clinician was asking me. And what they believe is that it's adenomyosis coming from the interna extending to the external subserosal surface. However, what we see on MR is what we see here. And in fact, It's not, because as radiologists, we know that adenomyosis is defined as that abnormal thickening of the junctional zone, sometimes with T2 bright, T1 bright cystic spaces within. So we know that a normal junctional zone is less than 8 millimeters and greater than 12 millimeters is abnormal and increases your likelihood for the detection of adenomyosis. Solid invasive endometriosis, or what the clinicians term posterior adenomyosis, is a very separate disease entity to adenomyosis. And as we see here in this example, the junctional zone is completely normal. There is normal myometrium interposed between the junctional zone and this abnormality, which is stuck on the back of stuck on the posterior uterus. So I think it's really important to get the terminology right and to just gently guide your clinicians toward using this terminology rather than the more confusing posterior adenomyosis. So MR is really important for detection and planning, surgical planning of bowel involvement. And the reason that is because the endosurgeons need to know if there's going to be a large proportion of bowel resection, because that will often require a colorectal surgeon to be present at the operation. And I don't know what resourcing is like in your part of the world, but in Australia, trying to get an endosurgeon and a colorectal surgeon into the room at the same time is no mean feat. So when they know in advance that this needs to happen, they can plan their resources more carefully and really identify those patients and not waste the colorectal surgeon's time and not waste theatre time for this surgical planning. So bowel involvement and using MR to really help guide that surgical planning is really important. Additionally, it provides ability to consent the patients accordingly. Are these patients going to be expecting a colostomy at the end of their operation? They don't want to wake up and find out that that's the case. So it really guides counselling and consent. And as I said, it really helps surgical planning. Depending on the level of experience of your endosurgeon, you'll find that the surgical management will require a colorectal surgeon depending on the disease depth. So there are different types of surgeries. There's a shave, there's a wedge resection, disc resection, and anterior resection. And being able to predict that prospectively really helps with the planning of the resources required for the operation. In the literature, MR is reported to be accurate for the assessment of bowel involvement in DIE in the order of 92 to 100% sensitivity, with specificity sitting around 75 to 100%. At my organisation, we did a retrospective study looking at using MRI to try and predict the need for a colorectal surgeon. And what we found was that if MRI reported a bowel lesion and if the lesion was greater than 20 millimeters in length or was invading into the muscular or submucosal layer, then that was a very good predictor for the need for a colorectal surgeon. When we're talking about bowel involvement in this context, we're really talking about involvement predominantly of the rectum, but also of the sigmoid colon, as this is the most commonly affected sites and can present with symptoms of hematochezia and dyschezia. Lesions can be classified in a number of different ways, but the one that is most important to the gynecologist is depth of invasion. They want to know serosal, muscular, or submucosal mucosal invasion. So let's have a look at what that looks like. So here we have a case of a lesion involving the upper rectum and posterior cervix, and we can see that the green arrow points to a band of adhesions which is coming out across to attach or to involve the anterior rectum. It's subtle, and I think it's quite difficult to see, but there is some subtle T2 dark thickening of the serosa, and as I've said before, there isn't usually a lot of high signal in the T1 fat saturated sequences with this form of the disease. Here we have a different case, and I think this one illustrates again that very subtle serosal thickening that we can see. Now, I think serosal thickening is actually one of the hardest lesions to detect on MR, but it's really not that relevant for my surgeons because the majority of my endosurgeons, I should say, will strip these kind of lesions on their own without the presence of a colorectal surgeon. So they're happy to deal with this on their own. This is also a reflection of local practice. Others might be comfortable stripping this off themselves. Others might want a colorectal surgeon present. So in my practice, it's not such a big deal, but for others, it may be quite challenging and difficult to diagnose and quite important depending on the level of expertise of your endosurgeons. Here we have the classic muscular invasion, the so-called mushroom-shaped lesion, which is of muscle signal intensity, has a relatively regular, mildly thickened T2 hyperintense layer above in keeping with an intact submucosa. So we've got muscular invasion here. And then here for comparison, we have a lesion which has irregularity of that overlying T2 bright submucosal layer, suggesting submucosal invasion. Now, the truth is muscular invasion, submucosal invasion is a difference of a couple of millimeters from a histological perspective. Am I truly going to be reliable in differentiating between these two? I don't know. Depends on your day. The reality is, from a practical perspective, both of these require a colorectal surgeon to be present in the operation. And if I overcall or undercall this, I don't get too fussed. As long as I predict accurately that a colorectal surgeon is going to be present or needed to be present, then I've done my job. Endometriosis involving the genitourinary tract. When the bladder is involved, it's more frequently the posterior wall, as demonstrated in this case, and is very often associated with involvement or obliteration of the anterior cul-de-sac. Patients with endometriosis involving the bladder usually present with fairly non-specific symptoms such as dysuria. Cyclical hematuria is less common, and when present is suggestive extension of endometriosis through the detrusor muscle with mucosal involvement. At MR, solid endometriosis of the bladder appears similar to other solid endometriosis with a poorly defined infiltrative or nodular lesion with typically low T2 signal intensity, may have some foci of T1 bright signal as demonstrated in this case. And here we have a different example with a lesion involving the ureter. So if we look at the central image here, we can see that really T2 dark deposit of endometriosis, which has this subtle T1 high signal, but we can see has proximal hydroureter. And as I've said already, endometriosis can occur in all sorts of weird and wonderful places. So here we have them involving the round ligaments. Here we have the anterior abdominal wall. Here we have the canal of Nook. My endosurgeons didn't believe me when I called this, but anyway, I proved right. Rectovaginal septum, and yes, that tiny little ditzel did end up being endometriosis around the spleen. So in summary, I hope that I've given you a bit of background about endometriosis, and clearly I'm passionate about it. I've dedicated most of my career to looking at this disease on MR. But it's a really fascinating disease, and it affects a lot of women. A lot of women have pelvic pain. Endometriosis is really common. And as I sort of said to you, it's really women come towards the end of this long journey before they get this diagnosis, and it's been a hard journey for a lot of them. So if we as clinicians can help in part of that management, then I think it's a really satisfying and important part of the job that we do. I've talked about the background of the disease, a little bit about the pathophysiology, a little bit about the common locations. I've tried to give you some ideas around and understanding around who should really get an MRI, and that is largely guided by some the European Society of Urogenital Imaging providing their guidelines. But really, it's reserved for those patients for surgical planning, for those cases where ultrasound hasn't really been helpful, and also it's a really good problem-solving tool. I've talked around the MR technique. As I said, I have personal preference of how I like to do things. There's some guidance in the literature. Key sequences are the T1 fat-saturated sequence. I really like the 3D T2 space because it allows me to do those volumetric reformats, which are really helpful when you're trying to detect disease in unusual locations. And we've gone through the many, many different phases of endometriosis. So I hope that you found this enlightening. I hope you've found some benefit to this discussion. And thanks for your time. Cheers.
My name is Emmeline Lee. I'm a radiologist from Perth, Western Australia, and I'd like to thank Radiopedia for the opportunity to speak today. I'm going to be speaking about subfertility. I know that is not an issue that you encounter on a day-to-day basis in the hospital. However, you will see this if you do any reporting at all for the community because it is an increasing clinical issue worldwide. In fact, 1 in 9 pregnancies in Australia are now conceived using some sort of help from our gynecological colleagues. And all of these ladies need imaging, which is integral to the investigation of subfertility. These are my disclosures. A couple of definitions to begin with. So infertility is the inability to conceive despite regular, unprotected sexual intercourse for a year, whilst the definition for subfertility is a little bit more flexible in that it's really any form of reduced fertility with prolonged time of unwanted non-conception. I'm going to start and end with this slide because as radiologists, what we have to produce are good reports that your clinicians want to read. And essentially, it's really what they want to know and they need answers to their questions. So if a gynecologist sends a lady to you for a scan to investigate fertility, what they really want you to exclude would be problems with the uterus, including Mullerian duct abnormalities. They want to know about the endometrial thickness and homogeneity and whether that is appropriate for the time of the cycle. They want to know whether the cavity is okay, whether there are any intracavitary lesions, including polyps and fibroids. They want to know whether there's evidence of endometriosis. They want to look at the ovaries, and in particular, they want to exclude PCOM, and also they want you to exclude hydrosalpinx. Why is imaging so important? Because we need to cover all of the lesions that we talked about on the previous slide and more. So what we can do is we can aid your gynecologist in making decisions regarding therapy, and also sometimes as radiologists we can actually provide the therapy itself. So in this lecture, I'm going to touch on a few things. We're going to spend most of our time talking about ultrasound, but we're going to chat a bit about hysterosalpingograms and hycoses, and touch on saline infusion sonograms, MRIs, and at the end, a little bit about therapeutics. So the mainstay of investigations for subfertility is transvaginal ultrasound. You should start off with a transabdominal ultrasound because that gives you a broad overview of what is going on. Sometimes some lesions are better seen transabdominally, such as big fibroids. However, I would consider a transabdominal ultrasound by itself not good enough for the investigation of fertility. You really do need to go on to a vaginal scan, and that should be a high frequency probe, and you should be able to produce a good quality 3D coronal or VCI plane, primarily to look at the external contour of the uterus. And whilst you are doing your vaginal scan, you should be assessing for tenderness and mobility of all the organs, because that's really acting as another hand and acting as a part of clinical examination in a way. You need to report on that as well. We're going to start systematically and talk about the uterus first. We're going to begin talking about structural Mullerian duct abnormalities. I'm going to be controversial to begin with by telling you that there is no fully accepted classification system for structural Mullerian duct abnormalities, and it comes down to a battle of two superpowers. It's the American system versus the European system. They are actually very similar, but the main point of difference between the Europeans and the Americans is that the American system includes an arcuate uterus, whereas the European system does not. In Australia, the American system is mostly the one that is used, and that is the one that I'm going to concentrate on today. So there's no right or wrong classification system to use. I just think you need to pick one that you are familiar with, that you can use consistently, one that your referrer likes. So it would be really good to confer with your colleagues to ask them which system they would like and use that system. So your main role as a radiologist reporting subfertility scans would be to decide, first and foremost, is there actually a significant structural Mullerian duct abnormality? So you need to look at the internal contour and decide, is there a significant dip or not? And if there isn't, well, it's going to be normal. Otherwise, if you decide that there is a problem with the internal contour, you then need to look at the external contour and report, is there a fundal cleft? And the main things to report would be to look at the internal midline septation. You want to look at the interosteal distance between the two ostia, and you need to report the wall thickness, which is the line from the top of the fundus to the interosteal line, because these are the lines that will help your gynecologist decide whether to operate or not. On a day-to-day basis, the main issue that most radiologists face when there is a significant internal cavity issue is to decide whether the uterus is a bicornuate type uterus or whether it's a septate type uterus. And in order to separate these two, you need to look at the external contour and decide whether there is a significant fundal cleft. And by significant, most people would say anything over 1 centimeter would be significant. So if it's shaped like a heart in that there is a significant external contour as well as a significant internal contour problem, you're dealing with a bicornuate uterus. Whereas if there is no significant fundal clefting on the outside of the uterus, but there is internally, you're then dealing with a septate type uterus, which is by far the most common. Whilst both septate and bicornuate uteruses are associated with problems with either falling pregnant or once there is a conception, there sometimes is problems with the baby itself, they are managed completely differently. And this is why it's really the radiologist's responsibility to report this accurately, because it really helps your clinicians make decisions about what to do. Because if you report a septate uterus, they may contemplate surgery, whereas if you report a bicornuate uterus where there is a fundal cleft, no surgery can be performed. 3D ultrasound is really good at distinguishing between the two if it's a good quality ultrasound, and sometimes saline infusion might also help. But if you have any doubt, definitely refer the patient for an MRI scan. In terms of when uterine septations become relevant, there are lots of publications and lots of different opinions, and lots of people do different things. However, most people would agree that unless a septation was over 15 millimeters, generally speaking, people would not operate. So I guess I've put this slide up here just to show you the different lines which we talked about earlier. So once again, talking about the interosteal distance, talking about the internal midline septation, talking about wall thickness. They're the lines that you should be reporting as a radiologist to help your clinicians make decisions about therapeutics and surgery. I'm going to start talking now about the different Mullerian duct abnormalities. So the class 1 defects are the ones where there is complete agenesis or hypoplasia of the uterus. Most of these ladies know about it really early on because they present with primary amenorrhea. So when you scan them, you cannot see anything. No uterus because it has failed to form. Now, the class 2 uteruses are the unicornuate uterus. So the uterus is a single cavity. So it really looks a bit like a sausage, to be honest. It doesn't look like the normal shaped uterus, and that is due to a failure of formation of one side. And you may have a little remnant bit, and that is a unicornuate with a remnant horn. That's a bit that you should also look for if you see a unicornuate uterus. And this is what I mean about a sausage shape uterus. So you really have just that one cavity, and it's usually pretty obvious on 3D ultrasounds. It can be quite tricky on 2D ultrasounds because sometimes, as you know, the uterus can, sit in a different position. So you do have to make sure you do good sweeps through the uterus and be confident that this is what you're looking at. It's usually pretty obvious on HSG, and if you do see only a cavity that's just the one side, you might want to go back and look at your speculum examination again to make sure that there is indeed only one cervix. Moving on to the class 3 and class 4 defects. Here, they're due to a failure of fusion. So what you will see is in these two entities, you will see a significant fundal cleft. So the external contour is really dipped. And here we're talking about the didelphys uterus and the bicornuate uterus. The difference between the two is really that with the didelphys, it's really widely spread. There's a very deep clefting, and there's usually two cervices, whereas with a bicornuate uterus, there is a significant cleft externally and a significant internal clefting, but there's usually only one cervix. So here's an example of a didelphys uterus, and you can see how widely spread it is, plus you can see the external cleft, as opposed to a bicornuate uterus where you do see the external cleft, but only one cervix because they're joined in the midline. Moving on to class 5 and class 6 defects. Here it's due to a failure of resorption. So what you get is externally, you have an intact fundus, but internally you will have a spectrum of issues to do with how much clefting there is. So I mentioned before that a septate uterus is way more common than a bicornuate uterus. And what you need to do is make sure you report the length and thickness of the septum, remembering that there is no external fundal clefting with a septate uterus. Here's a really good example of a complete septate uterus with an intact fundus at the top, but internally you see two separate cavities and indeed two cervices. And when my colleague actually did a speculum examination and saw that there were two cervices, he then put catheters into both cervices and contrast through both tubes. And we spoke a little bit before about how the European classification does not include an arcuate uterus. Once again, that is an extremely controversial topic. The Americans definitely classify it, and there are lots of papers that talk about how it is fairly controversial and does it impact on clinical practice. Yes, it does, because if you don't report an arcuate uterus as per the European system, you actually will find that you're going to be reporting more subseptate and septate uteruses. As to the subtle difference between a subseptate and an arcuate uterus, it probably doesn't matter clinically because most gynecologists would not operate on these anyway. 3D ultrasound is pretty good, but once again, I will say to you that if you are not sure, it's best to get an MRI scan. A couple of other little practice points regarding structural Mullerian duct abnormalities. Remember that with IUDs, you can get pregnant if they're not put into both horns in a true bicornuate or true septate uterus. So you can see pregnancies in one horn if you have only a single IUD. Remember that with the blind or rudimentary horns that are associated with unicornuate uteruses, that they may cause significant pain and may actually need surgical management. And I had a really interesting case a couple of years ago. I work in a tertiary hospital and a lady came in with right iliac fossa pain and it was thought that she had acute appendicitis. And when they actually operated on her, they found that her pain was due to blood within a blind horn and that she had an undiagnosed unicornuate uterus. Remember also that if you have a significant structural Mullerian duct abnormality, that there is an association with renal tract anomalies, so you should also be scanning the kidneys as well. In terms of practicalities, I found a really good article which was produced by a group out of Melbourne, which gives a really excellent overview and good practical advice as to how to classify Mullerian duct abnormalities. So I appreciate that this is a crazy busy slide, but I'm hoping that I will be able to summarize it for you. So if you're reporting these, you need to look at the 3D reconstruction of your uterus and go, is it a normal shape or is it a sausage type shape? In which case you're talking about a unicornuate uterus, and go down that route. If it's looking fairly much like a normal shaped uterus, you need to look at the external contour and decide whether the cleft is greater than 1 centimeter. If there is significant clefting externally, then you have to decide whether it's a didelphys or bicornuate uterus. If there is no external clefting externally, then you look at the internal indentation and you do your measurements. And if it's less than 1 centimeter, you can consider that normal. If it's between 1 and 1.5 centimeters, that's considered arcuate. And if it's greater than 1.5 centimeters, then you're talking about a septate type uterus, and that's when it becomes important for your gynecologist. Moving on to the endometrium now. we're going to talk about how to report these. So I would encourage you, when you report a pelvic ultrasound, not just for fertility, but for everything, you need to relate this to the day of the cycle, because the endometrium totally changes according to whether a lady has ovulated or not. So you need to report the day and length of the cycle so that your gynecologist knows when the ultrasound was taken and whether the thickness of the endometrium is appropriate for that day of the cycle. You need to also make a remark about the homogeneity and the vascularity of your endometrium. The gynecologist is most interested in whether there is a problem within the cavity, because if there is, this can relate to recurrent implantation failures and recurrent miscarriages. And when I talk about intracavitary lesions, I am essentially talking about polyps and fibroids. You all know what an endometrial polyp looks like on ultrasound, so you know that it's usually echogenic and that there's usually a beautiful feeder vessel with a characteristic vascular stalk. That is pathognomonic of an endometrial polyp. These are best seen in the first half of the cycle, in the proliferative phase, when the endometrium is thin and hypoechoic. Intracavitary lesions can also comprise of fibroids, which look quite different to polyps. So these are usually hypoechoic and they usually have some vascularity, but usually not a characteristic feeder stalk. These are best seen actually in the secretory phase, which is when the endometrium is echogenic, and so the fibroids actually really stand out at that time. If you do see a fibroid, your gynecologist wants to know whether there is distortion of the cavity and whether the fibroids are sitting within the cavity. Here's a nice example of a intracavitary and submucosal fibroid. If you're not sure, a saline infusion sonogram may be quite useful in helping delineate how much cavity involvement there is, and this can help your gynecologist make decisions about operating or not. Don't forget to talk about other fibroids and adenomyosis as well. They need to know this, although these don't tend to impact on fertility. I do want to spend a little bit of time talking about fibroids because they're very common and they are a great source of confusion for some. I think most of you are now aware that there is a FIGO classification of fibroids, which is increasingly being used by radiologists and clinicians around the world. So this classification system is so great because it is actually very easy and it lends consistency to reporting. So I think the ones that are most important for fertility would be the types 0, 1, and 2, which are the submucosal and intracavitary ones. They are the ones that the gynecologist usually would operate on if they think that a lady has problems with fertility. Now, the types 3, 4, and 5 are the most common types that you will encounter in daily practice. They're the intramural ones. It's just really good to describe them, but usually they don't impact fertility. Type 6 and 7, which are the subserosal ones, don't impact on fertility either, but it's really important to distinguish the pedunculated ones, the type 7s ones, from the solid ovarian lesions. And this is why I'm mentioning this today, not because of its impact on fertility, but because I think a lot of people get confused between these and the solid ovarian lesions. So make sure if you see this, that you are looking to see that you can see an ovary separate to it. That would be the most important. Moving on to ovaries now. We're going to chat about antral follicle counts. We're going to chat about polycystic ovaries and endometriomas. But before we do that, I want to emphasize a really important practice point when you are reporting for fertility specialists, which is, are the ovaries accessible when they do their transvaginal ovarian harvesting? Because sometimes you might find that your ovaries are stuck down posterior to the uterus, or it might be posterior to bowel. Now, in that instance, you will find that those ovaries will not be accessible. And it's really important to report these because your fertility specialist does not want to get any surprises on the day of the egg retrieval. I also mentioned before that when you are looking at ovaries, that you should be talking and reporting about their mobility and tenderness, because if there is decreased mobility and lots of tenderness when you're scanning vaginally, that might be a good sign that there are problems with endometriosis. A little bit about antral follicle count to start off with. So gynecologists use these to determine fertility potential and to plan IVF protocol. So usually now people are using AMH, which is a blood test, as a marker for ovarian reserve, but they still rely on us to report antral follicle counts because it is important to determine the dose of their fertility drugs. So make sure that there is good and accurate counting, and this should be done on vaginal scans only. It's not very accurate if you're doing the count transabdominally. Now, I want to spend a bit of time talking about the very common condition of polycystic ovaries. I think there's quite a bit of confusion amongst the radiology community as well as in the general community about the difference between PCOM and PCOS. I want to direct your attention to this article. It's actually an international evidence-based guideline which is published in 2018 for the diagnosis of PCOS, and it was a multidisciplinary team that published 200 odd pages about polycystic ovarian syndrome, of which one page is to do with PCOM, which is polycystic ovarian morphology, which is what radiologists have to report on. I've summarized this page for you, and it's essentially, how do we diagnose PCOM? And this is if you see 20 or more antral follicles, that is, this tiny little follicles between 2 and 9 millimeters, and or greater than 10 cc's in volume. But if you're going to use the volume measurement, they want you to exclude the large cysts and corpus luteum from that volume measurement. One of the practice points is they would not want you to make the diagnosis of PCOM if a lady is less than 8 years post-menarche. The reason is that in adolescence, whilst their cycles are starting to settle into a pattern, you can get lots of follicles, or what I would describe as multifollicular ovaries. Do not call this PCOM if you have a teenager who's less than 8 years post-menarche. They say in the document that a transvaginal scan is much better than a transabdominal scan in making your diagnosis, and particularly in the counting of follicles. They also say in the document that you should be reporting which approach you use, whether it's TA or TV. They would encourage you to report your ovarian size in 3 dimensions in millimeters and the volume in mils. They want you to report the follicle number per ovary, and don't forget as well as they want you to report the endometrial thickness and appearances. So I mentioned before the very important difference between PCOM, which is polycystic ovarian morphology, versus PCOS, which is the syndrome. And us as radiologists, we are in the business of diagnosing PCOM, which is an ultrasound diagnosis of greater than 20 antral follicles or greater than 10 cc's in volume, that supersedes the Rotterdam criteria. And you should be using the international consensus criteria, which is what we've just talked about. PCOS, on the other hand, is an issue which the clinicians usually diagnose. It needs 2 out of the 3 positive criteria. You either diagnose that on clinical grounds, biochemical grounds, or ultrasound grounds, but it needs 2 out of the 3 of these to be positive before a lady is labeled with PCOS. So really, we are not really in the business of diagnosing PCOS. It's PCOM that we are responsible for. Moving on to endometriomas and endometriosis now. You all know what a classic endometrioma looks like, which is the cyst, which is filled with fine internal echoes that looks like ground glass. Remember, don't call these solid because they're not solid, because if you cut through them, it is blood. So you can tell the difference between this and a solid issue because there is no vascularity in these, and there is posterior acoustic enhancement. Sometimes they have echoes within them, and these just represent acute bleeds into an endometrioma. Remember that how you differentiate these from a hemorrhagic cyst would be to ask for old imaging, and if it's persistent, it has to be an endometrioma rather than an acute hemorrhagic cyst. If you don't have old imaging, bring the lady back in a few weeks to confirm that it's still there. Moving on to the tubes now. So your main thing to exclude on scanning for subfertility would be hydrosalpinx, which is a fluid-filled tubular structure, and it can be quite large. And the pathognomonic thing would be the presence of incomplete septations, and sometimes if you turn on it, you might get what they describe as pearls on a string. Now, obviously, a blocked fallopian tube might manifest as a hydrosalpinx, but sometimes we don't see that until we do a HSG or hycosi. More on that later. Moving on to the adnexa now. Essentially, here I'd like to just raise the issue of deep infiltrating endometriosis, or DIE, and here you are actually beyond, the ovaries, you are beyond the tubes, you are looking to see whether you see nodularities, you're looking to see whether there are any nodules against the pelvic side wall or along the uterosacral ligaments, or sometimes you might see it on bowel as well. Don't forget to talk about the pouch of Douglas when you're actually doing your subfertility scans. Essentially, you're looking for free fluid and you're looking for hemorrhage within that, because that might be a sign of DIE or endometriosis. You also want to make sure that the pouch of Douglas is not obliterated, because if it is, you might want to think about endometriosis. Moving on to diagnostic procedures now, radiologists play a really, really important role in establishing tubal patency, either with the HSG or hycosi. Sometimes we're asked to interrogate the cavity, and we do that using saline infusion sonography, and that's primarily to look at intracavitary fibroids and polyps. So a HSG has been around for a long time now. You all know that when we do the HSG, you also not only just do this for tubes, but you might want to look at the cavity as well and describe it. And also it's a really good test to look at the internal contour, so you can exclude major structural Mullerian duct abnormality this way. I'm just going to show you a hycosi now. Some of you may not have seen this before, so look at the echogenic tube on the right, and you can see now the contrast moving to the left, and you can follow the tube all the way around to near the ovary, and now you might start to see spillage of contrast. Moving on to saline infusion sonography. So just a short clip of a saline infusion sonogram. So saline is hypoechoic on ultrasound, and you can see the little polyp that's sitting on the posterior wall. So in this way, by outlining the cavity, you can see intracavitary lesions really well, and you can see a little polyp that's sitting in the posterior wall here. Moving on to therapeutics now, most people will know that HSG or hycosi is not only diagnostic, it can be therapeutic as well, in that about 30 to 40% of women who are subfertile who have a hycosi or HSG will get pregnant naturally in the first 6 months following this. And I'd like to talk about a few other therapeutic procedures that radiologists are increasingly getting involved in. I think lots of people are now aware that Lepardol flushing is now endorsed by multiple colleges around the world as being superior to HSG and hycosis for the therapeutics in the subfertile woman. Traditionally, that's been fluoroscopically guided, but people have started doing this using ultrasound guidance. I think if you are going to be doing this, make sure that you are aware of the safety issues, make sure you use imaging guidance, and to make sure that you are looking for intravasation, and to stop if you see intravasation. You also want to make sure that the lady's thyroid function is good both before and after your Lepardol flushing. Some of our interventional colleagues have started doing cannulation of blocked tubes. It's a fast and easy procedure most of the time, and it can make a world of difference. Some of our colleagues are also using MR-guided high-intensity focus ultrasound ablation of fibroids, and that's been very successful. I just will say a little note here in that if a lady is planning pregnancy, that they should be avoiding uterine artery embolization because that's associated with some bad outcomes. So we've come back to the slide we started with, which is what gynecologists want to know, and I hope we have covered all of this today. In terms of what to take home from this lecture, I hope you remember to include the day of the cycle and the cycle length. That is of fundamental importance in all your gynae scans. I'm sure you will all be doing good quality TV scans with good quality 3D coronal views. Don't forget to report systematically from the uterus, looking at the external contour and the internal cavity shape, and to exclude intracavitary lesions. You want to look at the ovaries, primarily to exclude PCO and endometriomas, but don't forget to make a comment as to whether they are accessible for your fertility specialists. Don't forget to look at the nexa for signs of endometriosis and to exclude hydrosalpinx. And remember that radiologists are increasingly important now in therapeutic options for subfertile women. If you have any questions or comments, please email me, or in fact, connect with me on LinkedIn. I'd be very happy to see you on that platform. All the best, and thanks so much for listening.
I'm now joined by the speakers from the two lectures we've just watched, Natalie Yang and Emmeline Lee.
Hey, Sasha. Hi, Emmeline.
Hello, everyone.
Hi, guys. How are you?
Good. How are you?
You're very well. Nice to see you guys.
Yes.
Lovely to see you both, and I really enjoyed both of these talks, and thank you so much. And it's really a pleasure to see both of you on the screen as well. So we might just head into some questions now. I'll have a question for Natalie first up, please. Natalie, so I'm really interested in your experience with correlating between ultrasound and MRI in endometriosis for identifying the sites of disease. So one of my personal frustrations has been having cases where, for example, a rectal lesion has been well seen on ultrasound, and then I'm looking at an MRI and I can see there's adhesions in that region, but I feel that I cannot see in some cases the rectal nodule that was seen on ultrasound. So what's been your experience with the correlation between the two modalities?
Yeah, so my advice with that is MDM and audit. Because the reality is that, especially when you're starting out with this practice, and I guess I'm very privileged that I work in a place where those things can happen, but there is a level, I think, of distrust by gynecologists, or uncertainty, I think, with respect to MR findings. And I don't know what practice is like worldwide, but certainly in Melbourne, a lot of the gynecologists will trust a COGU or a sonologist ultrasound versus a radiologist ultrasound. And similarly, that sort of translates a little bit to radiology in general. So it has taken me the greater part of 10 years to build that trust with my clinicians. And it really speaks to what Emmeline was talking about in her talk, which I fully back. You need to know what your clinicians want to know, and you need to work to that. And I really believe in the process of MDM and audit, because then it doesn't become a she said conversation. It becomes a, well, that's what you think, that's what I think. What does the surgery find? And really at the end of the day, it comes down to that audit. It helps you refine your practice as a radiologist with respect to the interpretation of the MR. But then also what happens is that through that process, the gynecologists then start to go, well, hold on, Natalie was right about that last time. So that then builds trust and confidence in yourself, but also trust of your clinicians in your abilities, I think. So I'm really lucky in that we've been doing MDM now for the greater part of 10 years. And I work very closely with the lead sonologist who does the ultrasound. But also I think the great advantage of MR is that given that endometriosis transvaginal ultrasound is such a specialised niched area, it's actually really hard to get women into those clinics. And so sometimes what ends up happening is that an ultrasound gets done, no one's really clear of the validity of it, comes to MR, and then what I say goes. So it's really just, I think, a lot of hard work and blood, sweat and tears, working very closely with both your sonologist, and I don't do ultrasound, so I have to work very closely with my sonologist, but also with the clinicians and getting the feedback from the surgery. And through that, you will refine your process and understand more clearly what it is that you're seeing on your MR.
Can I jump in and ask a question on that note, Natalie? So I was really interested in you talking about MRIs and, and how you use it, or your clinicians use it for preoperative planning. How do you select the patients, to have the MR? And do you think that all patients going to surgery with the diagnosis of endometriosis should have a preoperative MRI?
That's a really great question, Emmeline. And I think it little bit depends on local practice. So one of the key things that I sort of alluded to in my talk, but I probably didn't emphasize enough, is that especially in Melbourne with resourcing limitations, to have an operative list that has both an endosurgeon and a colorectal surgeon at the same time is extraordinarily, one, difficult to coordinate and very expensive. So you want to be certain that when you say a colorectal surgeon is needed, that you are correct. And really that's what boils down to the decision making around, for me, the MRI. So the worst thing you can do is say, yes, there's a lesion, and then the colorectal surgeon sits there for the whole list, but twiddling their thumbs. Or the endosurgeons go into an operation thinking that they don't need a colorectal surgeon. They open up and they go, oh my goodness, I need help. So you want to avoid both of those situations. So from our perspective and the experience that we've gathered, all of the patients that are planned for theatre go through the MDM process. They all get MRIs, so these are the ones that are going to theatre, and in conjunction with a transvaginal ultrasound. So really, surgical planning, absolutely, I believe that they should all be getting MRs. Now, 10 years ago, that probably wasn't the practice, and there has been this very slow education of the gynecologists, building that trust in MR because, a decade ago they sort of didn't think it was necessary, but now they're starting to behave like general surgeons and they want everyone imaged before they go to theatre. So we're seeing more of that. But I think at the end of the day, if the patient has very strong symptoms of dysgeusia or hematochezia, so blood in their stool or really painful bowel action, then I think that is a really good indication to do an MR. Particularly if the transvaginal ultrasound doesn't show anything, because as you would know, Emmeline, the field of view is relatively limited, and endometriosis can occur in the mid to upper rectum, and those areas aren't well visualized on ultrasound. So MR is great for that upper rectal portion of bowel involvement. And I think also there's a subset of transvaginal ultrasounds whereby the visualization of the bowel is really limited, be it because there's a really bulky fibroid uterus that's getting in the way, or that the patient really can't tolerate that very dedicated look at that anterior rectum, which I think can be quite an uncomfortable process for women to go through. So in that setting, yes, I believe that they should all get MRs. If they're going to go to surgery and there's concern about severe bowel symptoms, I would be getting an MR as well.
Yeah, I agree with you actually that on ultrasound, the rectum is very difficult for us to see nodules of DIE on. So I in my local practice, if someone has severe bowel symptoms and we don't see much on ultrasound, I usually do suggest an MRI. So it sounds like, our practices are fairly similar.
Yeah, and I think it's hard because now this is for our overseas audience. Within Australia, the funding of MRI is the MRI in general has got very strict rules, and so access to MR is a major challenge. And in Australia, I don't understand why, but for the indication of endometriosis is not rebatable from the government, so is not Medicare billable. So patients either have to go to a place where, public system whereby the cost is absorbed by the hospital, or they have to pay out of pocket. So that also, I think, muddies the waters in terms of gynecologists wanting to refer to MR, because it is an additional cost, and often in private land, it'll be an additional cost to the patient.
Actually, can I throw in a somewhat related question about the various modalities that we've got available differently between us? So Emmeline, you talked about performing hycosi and saline sonograms, which is something that certainly not all radiologists will do, and in my practice we don't have that. So I'd be very interested to hear from you what's actually involved in that from your point of view, and how do you integrate that into radiology practice?
It's a great question, Sasha, because I think it is, it has been quite hard for me to integrate that into my practice, but I've really found that I've really enhanced my practice by using those, in particular the saline infusion sonogram, because that's really helped me sort out lots of problems, and it's very easily incorporated into your practice as a radiologist. It's the same technique as doing HSG. So literally it's putting in a speculum, putting in a catheter, which is exactly the same as a HSG catheter, but instead of putting in contrast, you would put in saline and do ultrasound at the same time. And in that way, we can interrogate the cavity absolutely beautifully, because the high frequency probes just are amazing for detail, and it's been great for looking at the cavity in particular to sort out whether there is or is not a polyp or a fibroid, an intracavitary fibroid, and that helps with surgical planning. And the other thing, which I didn't mention in the lecture, that I use saline infusion for a lot, is to look for the presence of adhesions. So for Asherman syndrome. So sometimes, ladies will have fertility issues because their endometrium is just so scarred down and so stuck down that when I put in saline, there's no expansion of the cavity whatsoever. That's in the really severe end of Asherman type syndrome. But in sometimes when even post DNC or post endometritis, ladies can have adhesions, which we see really beautifully on saline infusion sonography. And that really helps with gynecologists when they decide what to do, and that they may plan surgery. So that's for saline infusion. For hycoses, I think it's an alternative to HSG, and I use that in my practice where I don't have a fluoroscopy machine, plus it eliminates radiation. So for ladies that are bothered having that radiation dose, Hycosi is good and is a very, very good alternative to HSG. It is more expensive, but then there's no radiation. But it's the same technique, and instead of using non-ionic contrast, you'd be using either agitated saline or using a special contrast called XM foam. So that's a brand of contrast, and you do ultrasound and watch the filling and spilling of the tubes using the contrast. So I find that very, very useful, very fast. And for Hycosi, the advantage is that you can do the ultrasound prior and get a lot of information. So it's sort of like a one-stop shop type practice. Hope that answers your question, Sasha.
Just following on from that, I'm interested to understand, because I don't think probably not all practices would do 3D ultrasound, or maybe not have a lot of experience with it. And in your opinion, is that essential for diagnosing Müllerian duct anomalies? So, for instance, bicoordinate septate uterus, etc. If you don't have those 3 coronal reformats available, do you think that you can make that diagnosis, or do you think practice has now evolved that really we all should be doing it?
That's another really good question, Nat. I think I was quite strong in my lecture in saying that you absolutely need the 3D ultrasound to be clear as to what the fundus was doing at the top. And I truly believe that. So I think unless you have a really good quality 3D vaginal ultrasound where you can see the fundus of the uterus and make a really good assessment whether there is clefting or not, you cannot tell the difference between a septate and a bicornuate uterus. I really feel that, you just have to come, in your report, you have to say that you were not able to obtain the 3D ultrasound, and that you're going to have to say what's the internal contour is suspicious for a Müllerian duct abnormality. You can't really tell the difference between a bicornuate or a septate uterus from not doing a good quality 3D ultrasound. And I sort of feel that if you are going to be offering a service, you should be getting a 3D ultrasound as part of your armamentarium.
And just out of interest, clearly you work in a tertiary level environment. What about, are you seeing in the community practice, are you seeing, smaller peripheral radiology services providing 3D routinely, or is that not necessarily something that you see?
Yeah, I'm lucky enough to work in a tertiary environment, but I also work in a secondary in the hospital type community practice as well. Mm-hmm. So I see the breadth and depth of patients come through. And in my smaller practice where we are not offering the 3D really, mm-hmm. we do a handheld 3D. Mm-hmm. I'm not confident at all. And I always say, look, I'm not sure. We need to have a good quality 3D ultrasound, and or MRI if we are really worried that there is a significant structural Müllerian duct abnormality which would contribute towards a patient's subfertility. But yeah, I really feel that in the community setting, you can't be too dogmatic in what you say about major structural Müllerian duct problems.
In my experience, in terms of availability of 3D coronal reformat or the coronal formats, by far not all centres will have it, for one. And even in large centres, there might only be one machine that will have it and others won't. And so the patients, will be scanned on any of them. So yes, ideally would like to be able to scan them on the right machine and the right modality. But what you're alluding to there is that awareness of people who scan them and report them, in just taking that little bit of caution about making the diagnosis when you don't quite have the information. Would you agree with that, Emily?
Yeah, that's a very good point. It is just, I think we have to be less dogmatic in your reporting if you don't have access to a good quality 3D reformat.
Sorry, and I'm going to show my ignorance here because I don't do much ultrasound. How hard is it a machine accessibility restriction, or is it a training? Like, how hard is it? Say every practice in Australia had the magical 3D ultrasound. How hard is it from a technical perspective to train and learn on?
Yeah, that's a really good question as well, Nat. So it's basically, if you have a high-end machine, you can do an automatic 3D sweep and do a few fancy reformats, and you can train yourself very easily to do it. And that would be the best scenario. But if you have a transvaginal scan but no 3D capability, you can actually do a handheld 3D where you do your own sweeping and reformat it in that way, but you have to have a very steady hand for that. So you can train yourself to do it with, as long as you have a vaginal ultrasound, you can train yourself, but the really best quality gold standard scan would be machine-led, basically, automatic.
So step one is having the right software. And then step two, also having someone who's capable of using it, potentially. Yeah.
Step 3 would be someone capable of interpreting.
Everything
else in radiology, there are lots of people involved with lots of different skills, and we all work together to achieve an excellent result for the patient. So.
Absolutely. And that's great words to end on, I think, Emmeline. So I think it's a good point on which to round up this session. And thank you so much. It's been absolutely lovely to have you both in the same virtual room for once. So we're going to now go on and show a lecture on ultrasound of ovarian masses, which is recorded from me from last year's conference. And then after that, I'll be back to end the session with a couple of live cases that lead on from the talks that both of you have done before.
Wonderful. We look forward to it. Thank you, everyone.
Thank you. Best
Cheers.
wishes, everyone. All the best.
Bye.
Thank you.
Bye.
(2020) is, strictly speaking, the third year of the Radiopedia review course. And each time I find myself planning the next year's content as soon as the previous course is finished. So I have been looking forward to talking to you about ovarian masses for a very long time. And I'm going to be specifically focusing on ultrasound of ovarian masses. And that is not out of contempt for other modalities. Ultrasound is an excellent tool for problem solving at adnexal lesions, and CT, of course, is essential for staging. However, ultrasound is still the primary modality in assessment of adnexal pathology and is an excellent triage tool in tumour analysis. But this is only true if it is reported in a clear and consistent way. And so we're going to be discussing today how to describe ovarian masses in a standardized manner, how to convey risk so that the report is useful in guiding the referrer. And to this end, we're going to go through several of the recent risk stratification systems. And we're going to talk a little bit about recommendations for management for best patient outcomes. So I'm going to start off by being critical. But luckily, I'm not critical of anyone in particular, but of this fictitious report conclusion, which admittedly vaguely represents some of the reports that I have seen and probably written in the past. I'm going to take particular aim at the term complex cyst and suggest that you try to either reduce or eradicate the use of this term from your reporting vocabulary when describing adnexal masses. At the very least, don't use it as an isolated descriptor because it doesn't mean anything. My imaginary colleague goes on to say that the nature of the lesion is uncertain and recommend referral to a gynecologist. Now, that may be the right thing to do in some cases. However, if this is in fact a physiologic lesion, such as a hemorrhagic cyst, he may save the patient a lot of stress and money by recommending ultrasound follow-up instead. Alternatively, if the lesion looks like a cystic neoplasm, then he should be suggesting that they see a gynecologic oncologist, because surgical outcomes for malignant tumours have been shown to be significantly better in a patient operated by a gynae-onc specialist rather than a general gynecologist. And these images really just bring home the point about complex cysts. So both of these lesions may be called a complex cyst, but the one on the left has the typical appearance of a hemorrhagic cyst and will resolve, whereas the one on the right is also a complex cystic lesion in that sense, but is very concerning for a neoplasm. So I'm going to introduce you to 3 ovarian tumour at risk stratification systems. And if you're already thinking, do I really need to know all 3? Well, you don't. You may sway towards one or the other depending on where you live or what is locally accepted practice, but I do think it is helpful to understand all 3. So IOTA Simple Rules was the first stratification system that was developed by the European-based IOTA group and is almost a binary system where tumours are designated as either benign or malignant, and if they don't fall into either categories, then they're deemed inconclusive. The ADNEX model is a mathematical model that was developed by the same group as the IOTA Simple Rules and based on the same data sets. But as you can see, it is a scale which gives a percentage risk. And ORADS is essentially the American cousin of ADNEX and IOTA. It was developed in conjunction with the IOTA team, and it was based also on the IOTA data sets, but has adopted the familiar RAD structure such as BIRADS and TIRADS, where the risk of malignancy is subdivided into categories from 1 to 5, with 1 being normal and 5 being a high risk of malignancy. And I should preface from the outset that I have in no way any affiliation with any of these stratification systems, either clinically or financially. My only bias is the promotion of value adding in our radiology reports. So here's the outline of the IOTA Simple Rules. And you can see, as we mentioned previously, that there is a series of benign characteristics labelled from B1 to B5, and they are a unilocular tumour, a tumour with solid components, all of which are less than 7 millimetres in size, the presence of acoustic shadows, a smooth multilocular tumour that is less than 10 centimetres in size, and a tumour with no blood flow colour score 1, and I will go through the colour scoring system a little bit later on. Whereas the 5 M features or malignant features are an irregular solid tumour, presence of ascites, presence of at least 4 papillary structures, an irregular multilocular solid tumour if it is more than 10 centimetres, and very strong blood flow or colour score 4. And if the lesion has in at least one B feature, it doesn't matter how many, whether it's 1 or more than 1, but if it has B features and no M features, then the tumour can be classified as likely benign. And conversely, if it has any number of M features and no B features, then it can be categorized as most likely malignant. A tumour that has neither B or M features, or it has combination of B and M features, is inconclusive, and the IOTA Simple Rules cannot be applied, and further characterization such as specialist review or other modality imaging is necessary. And I should just point out that this image may be a very familiar picture for those who are familiar with IOTA Simple Rules. And this slide is, of course, based on and references the IOTA group, and even the colour scheme references the IOTA group, but just to take note that it's not exactly the same images because the specific cases are all out of the Radiopedia case library and they're referenced with the case ID numbers. So prior to releasing the IOTA Simple Rules, the IOTA group had come up with a set of terms and definitions which comprise the Iota lexicon, and I'm just going to spend a little bit of time just highlighting a few key points out of that lexicon. And in particular, this is probably the slide that addresses my gripe with the term of the complex cyst. So rather than saying that it's a complex cyst, one of these terms can really be applied. So a cyst may be unilocular or multilocular, so you can make that decision from the outset. Is it a unilocular or multilocular cyst? And are there solid components or are there not solid components? So it may be unilocular cystic, unilocular solid, if there are any solid components, multilocular cystic or multilocular solid, or alternatively a solid lesion. And you may have a predominantly solid lesion with some cystic components, and the arbitrary cutoff is if it's approximately 80% solid, then we regard that as a solid lesion. Another component out of the Iota lexicon is the term of the papillary projection, which we use quite a lot, and I must confess that when I first started reporting gynecological imaging, I was confused by this word because when does a nubbin on the cyst wall become a papillary projection, and when is it no longer a papillary projection, but is it now a solid component? And so it was quite useful to have this set of definitions where papillary projection is actually a subtype of a solid component. So if you have papillary projections, it is a cyst with solid components. It arises from a wall or a septation, and it protrudes into the cyst lumen with an arbitrary height cutoff of 3 millimeters. So if it measures more than 3 millimeters, it can be called a papillary projection. In order perhaps not to insult our collective intelligence, the Iota group have conceded that we may not always need to go through the full checklist of the simple rules, and that there are some benign lesions that are so typical that they may be diagnosed confidently from the outset. And so they have nonetheless provided us with a set of standard descriptive terms that would help identify these lesions. So unilocular or unilocular cysts with regular walls, which are generally simple cysts or cystadenomas, unilocular cyst with mixed echogenicity and acoustic shadows in a premenopausal patient. So in other words, a typical appearance for a mature cystic teratoma, dermoid cyst, or a unilocular ground glass echogenicity in a premenopausal woman. So in other words, features consistent with endometrioma. If any of these are present, it's sort of a gestalt diagnostic appearance. You don't need to go through the definitions of the simple rules. And likewise, they have offered some malignant, easy descriptors. So in a patient who's got an ovarian mass with at least moderate vascularity and ascites, and it is a postmenopausal patient, this is sufficient to regard this as a malignant lesion despite any other presence of any other features. And also in a patient aged more than 50 years old with a CA125 of more than 100, with no other factors of what the lesion might look like, this is sufficient to be suspicious of malignancy. And so just take note that this is the first time in all of these descriptors that CA125 has actually come into play, and we'll talk about that a little bit more further. I mentioned before the presence of an iota colour score. It is a very simple system where colour score 1 means no vascularity, colour score 2 is minimal, 3 moderate, and 4 is marked. So it's very subjective, but most of the time, certainly colour score 1 and 4 can be quite well differentiated. And it's actually quite easy to apply. So moving on to the iota adnex model, which, as we mentioned, is a mathematical sort of model which is derived from the same data set as the iota simple rules, but takes a somewhat different approach. Here we've got 3 clinical factors. So patient age, whether or not they're referred or they're being examined at an oncology centre. And the third at the bottom is the CA125, but this one is optional. So you can complete this and calculate this without without the CA125. And then there are 6 lesion characteristic factors. So maximal diameter of the lesion, diameter of the largest solid component. Are there not more than 10 locules? So 10 locules being a cutoff. How many papillary projections? And there will be a choice of none, 1, 2, 3, or 4 plus. Are there acoustic shadows present, and is ascites present? And so you can find this very easily if you Google IOTA ADNEX model. It should lead you to the correct page where this calculator is based on the IOTA website. It is free, and there's also an app for ADNEX model, which, as far as I know, has a cost. So go to the website. So ORADs developed, as we said, in conjunction between the IOTA group and some key governing bodies within the North American radiology system. So this is an article that was printed in the Radiology Journal of the Ultrasound Risk Stratification and Management System. And this is the key table which outlines the risk categories, the lesion descriptors, and suggested management. And we haven't seen suggested management given before. And this is one of the key ways in which the ORAD system is different to the other ones. So it offers suggestions for patient management. Now, with me putting this slide on here, you may think that I have put on text which is too small to read, and that I should be apologizing that there is text that's too small to read. And yes, I have put on text that's small to read, but I'm not going to apologize for it, because I'm not putting it there for you to read, but rather to see what it looks like so that you can now Google it. I'm making use of the fact that this is a straight to DVD video. So please Google ORADS ACR, and I think that should be sufficient. And I would suggest having this alongside the talk for when we get to the tumor analysis and case analysis part of the talk. And feel free to pause, of course, as you do that. And just to mention, of course, that this system is excellently summarized on the Radiopedia website as well. Risk assessment models that I've been talking to you about have been the subject of a vast amount of research, both internally within the IOTA group, but also through external validation. And this is something that I wanted to point out from one of the large analyses which assessed the ADNEX model and compared it to other frequently used ultrasound methods. And so this study and other studies have shown that the ADNEX model and simple rules in conjunction with clinical assessment are superior in their sensitivity and specificity to many other previously commonly used ultrasound methods, such as RMI, which was a popular tool in some areas for assessing risk of adnexal pathology. But of particular interest to me was this phrase in the conclusion that although the test performance of subjective assessment by an expert remains superior, the ADNEX model can help with differentiation between benign and malignant. So the subjective assessment by an expert remains superior. And this is an interesting point where, whilst we're talking a lot about how these systems might help us in the diagnosis, it's nice to hear that perhaps what we also need to be doing is just knowing our stuff. So what I'm hoping in the remainder of this talk, we will address the various risk stratification systems, but we're also just going to hone in a little bit on knowing our stuff about adnexal pathology. And I'm even going to be bold enough to take on the IOTA simple rules and offer my own keep it simple rules of thumb that sort of address the factors that we've described before, but really just bring it back to what you might be thinking about in your objective assessment of a lesion. And here they are. So firstly, big is bad, and this being rules of thumb, this is not always the case. So some big tumours are in fact benign. So for example, cystadenomas, and particularly mucinous cystadenomas, can get very big slowly before they're diagnosed. But in general, when the larger the tumours are, really the more suspicious they become. Secondly, solid is bad. Again, not in all cases. There are exceptions. The typical fibromas, for example, are benign, but in most cases, solid tumours are either malignant or you can't tell, and then you need to take them out anyway to get the histological diagnosis. Vascular tumour is bad, and the presence of ascites is bad. That holds fairly strongly true. And for a bit of good news, shadows are good. And as radiologists, of course, we're glad to hear that shadows are good. So what lesions tend to shadow? Well, it's predominantly either the dense fibrous ones, such as fibromas, or the echogenic components of dermoid tumours. So that's a large component of shadowing lesions. Shadowing calcifications is a little bit of a different category, because calcifications are not talked very much about in this analysis, and they can occur in a variety of settings. But by and by, if you've got lesion with shadows, this is a good sign. And a few extra points. So these are the less definitive ones, perhaps, to an extent. Septations are not necessarily bad, but are not physiological. So if you've got a lesion with thin avascular septations and no other features, this is not an indicator of malignancy. So for example, cystadenomas, and especially mucinous ones, will often be septated. Other lesions such as dermoid cysts can have septations. So although you may see septations in malignant tumours as well, they will not be the feature that will make you concerned, except if they are thick, very vascular type of septations. So septations are not necessarily bad, but not physiological. You won't, for example, see a follicular cyst or follicle with septations. Papillary projections can be bad, but are not terrible. And the reason I say that is papillary projections most typically are a feature of borderline tumours, and borderline are thought as tumours of low malignant potential. So whilst they need to come out, their prognosis is quite good. You can get papillary projections in more malignant tumours as well, and there's certainly overlap, and we'll look at that as we go through cases. But if you've got a lesion which has no concerning features other than the presence of papillary projections, you can be perhaps cautiously optimistic that it might be a borderline. And tumour markers have a limited role in stratification. So coming back to the stratification systems that we've seen, note that only the ADNEX model actually includes CA125, and when I'm talking about tumour markers, really here we're talking about CA125. Only the ADNEX model includes CA125, and even there it is seen as an optional feature. And so the IOTA group research has found that CA125 doesn't in fact contribute to differentiation between malignant and benign tumours, but it can help separate high-grade tumours from either borderline or low-grade tumours or from metastases. And this is particularly true in premenopausal patients, where the rate of false positives is high when CA125 is considered as a marker of malignancy at first diagnosis, due to, firstly, benign lesions that can cause so false positive rate is high due to benign lesions that can cause elevation of CA125, such as endometriomas and abscesses, and also increased rate of false negatives due to increased prevalence of borderline tumours and other rarer tumour types that do not cause a rise in CA125. So as we move towards the case review part of this talk, we will briefly revisit the main histological tumour types. Note that these are not complete lists, but just to remind you that the main tumour histological groups are the surface epithelial tumours, the germ cell tumours, and the sex cord stromal tumours. There's sort of a mixed bag of metastases, lymphoma, and other mixed tumour types, which are very rare. So surface epithelial tumours, serous and mucinous. Serous particularly is the most common, followed by mucinous. Both serous and mucinous have 3 subtypes. So the cystadenoma, the borderline, and the cystadenocarcinoma. So just a little reminder. So serous and mucinous. In general, mucinous tumours tend to be more septated. A serous cystadenoma will have either no septations or few septations, and typically, classically, a mucinous cystadenoma will have a few more septations, so thought to be somewhere between 2 and 10. And will also have potentially low-level echoes within it because of the mucin content of the tumour. As we move towards borderline tumours, what we see is the appearance of papillary projections, particularly within the serous types, but really within both. And in mucinous tumours especially, we note the increase in the number of septations. So if you see a tumour with lots and lots of septations, specifically more than 10, then you're hedging more towards borderline, knowing that there are, of course, overlaps between all these categories. And cystadenocarcinomas, of course, are much more complex with solid components and thicker and irregular septations, and potentially extension of tumour nodules outside the wall, so wall becoming more irregular. Other types to mention quickly is the clear cell and endometrioid. Just to remember, both of these are associated with endometriosis. And so if you see a tumour appearing within the setting of endometriosis, it is quite rare, but those are the common tumour types there. Endometrioid cancer also has a high association with endometrial, so cancer of the endometrium. So it's good practice whenever you're assessing an ovarian lesion to just review the endometrium as well and make sure there isn't a endometrial thickening or a mass. Brenner tumour is sort of something of a good guy that got mixed up with the wrong crowd. They're predominantly benign. They don't look like the rest, so they're typically a small solid tumour, but histologically they're surface epithelial tumour. Again, very rare. So, on to cases now. First case, incidental finding on ultrasound of an incisional hernia, so an incidental finding in an 80-year-old female. So we're going to just review this case first. So we see what is an anechoic lesion. So there are some septations and we don't see any solid components. So this is a multilocular cystic mass in the adnexa. It's got a couple of smaller locules and one larger one. Just looking for an overall measurement in there somewhere, so measuring just under 5 centimetres. And so there's nothing else to it. So 80-year-old female, obviously it's not normal for an 80-year-old female to have a 5 centimetre cystic lesion in her adnexa. However, there is nothing that's outwardly concerning about this. There's no solid components, there's no vascularity. The appearance overall is quite reassuring, so I would say that this is likely to be a benign lesion. So it's benign, such as a cystadenoma. So, and if we look at what our stratification systems say about this, so according to the IOTA simple rules, and at this stage, please do, I would encourage you to bring up the IOTA simple rules and the ORAD system and ADNEX model alongside. And so feel free to pause as you go along and trial out whatever systems interest you alongside these cases or through these cases. So in this case, IOTA simple rules, 1B feature because it's a smooth multilocular tumour. ADNEX model, you can punch in the numbers, I haven't shown you there, but it says 96% benign, and ORADS gives it a category 3, low risk of malignancy, 1 to 10%. So everyone's in concordance, and this case, I don't have clinical data for. She was followed up there. It wasn't excised, but it was thought to be likely cystadenoma. Next case, 20-year-old female. So we do have a CA125 provided here. It's 44. Presenting with pelvic pain and fullness. Going through the pictures here. So obviously it's a multilocular tumour and clearly there are more than 10 loculations. So it's a multilocular tumour with lots of loculations. We're not seeing any definite solid components, so we're going to call it multilocular cystic. There's a little bit of vascularity, so here and there, so we'd give it maybe a IOTA colour score 2, and everything else looks normal. So thoughts on this one? I've just gone through the various appearances of cystadenomas, and to me this appearance is very much in that borderline kind of category. So there's septations, lots of septations, but nothing else. So if we look at the IOTA simple rules, we're in that inconclusive category. None of the B features and none of the M features apply to this. ADNEX. So here's the sort of results table that I haven't shown before. This is the sort of results table that the ADNEX model gives you. So here we've got age of the patient, 22. We'll say this was not in this was not in an oncology centre, and we'll say that for most cases because we're just going to treat these as first presentation cases, first presentation to you in the community setting. This lesion measured 23 centimetres. There were no solid components. Yes, more than 10 locules, no papillary projections, no acoustic shadows, no ascites. And we, in this case, because we're given a CA124, we've entered it, but it hasn't really made any significant difference. I've tried it out both ways. And so according to this, we've got a 89% chance of benign tumour. And note that the ADNEX model not only gives you a risk of malignant versus benign, but it also gives you a breakdown of what the components might be. So if it was malignant, it's likely to be a borderline or low grade rather than, so it's not considered to have any significant risk of actually being a high grade tumour. So 89%. Benign, and ORADS category 4, intermediate risk for malignancy. So interestingly, these systems don't always correspond, and this is a good example of that. This is a lesion which on basis of ADNEX model has got high chance of being benign. Reality is anything from 10% risk of malignancy onwards, they would still operate. And of course, on clinical judgment and clinical acumen, based on the size of the lesion alone, regardless of the ADNEX model, this would require surgery. And this was, in fact, a mucinous borderline tumour, as we suspected. Next patient, history withheld. There's something here I'm not telling you. 75-year-old. So we have a multilocular tumour with a solid component and internal vascularity. So it's a multilocular solid. Somewhere here we've got the size of it, 5.7 centimeters. Vascularity score, so sort of moderate. So maybe we'll give it 2 or 3. A few septations have got colour in them. There's no shadowing. And this is a separate finding. So this is in the pouch of Douglas. We've actually got a separate nodule in the pouch of Douglas, which has got internal vascularity in it. So this is something that is not in any of stratification systems that you'll see, but we see that, and our level of concern is immediately elevated even more because there's a suspicion for a peritoneal metastasis in the pouch of Douglas. So, interestingly, by the iota simple rules, we have no B or M features. Whereas by the adnex model, 75-year-old patient, 57 millimeter tumour with a 3 centimeter solid component, no ascites, no acoustic shadowing, even without taking into account the solid component that we saw. This is very likely malignant. And if you look at the breakdown, we're concerned particularly about a high-grade primary rather than a borderline or low-grade. And by ORADS, this is a multilocular tumour with solid component, colour score 3 to 4. It's category 5, more than 50% risk. And note that here, so again, the ORADS model gives you indications of management, so management by gynae-oncologist, of course, for a category 5 lesion. So why do we have this discrepancy, or do we have a discrepancy? ORADS and adnex model are highly suspicious, but iota simple rules hasn't given us a malignant diagnosis. 2 points. Firstly, inconclusive lesions fall into that category where other assessment is required. So, of course, there's other clinical features and imaging features that will be taken into consideration. So, invariably, the diagnosis will be a malignant lesion for this. But the other point is, and I've withheld part of the history, once you had an elevated CA125, and if you remember our malignant easy descriptors, a patient over 50 with an elevated CA125, regardless of the appearance of the lesion, is considered to be malignant. So even by the initial iota system, this still falls into a malignant category. And the other part of history that I withheld, which sort of was probably not helpful at all, is that this patient actually initially presented with a breast lesion which was biopsied and thought to be of ovarian origin. So it was a ovarian metastasis to breast was the initial presentation. And so this was a high-grade serous cystadenocarcinoma. All right, moving on from, so all of those were examples of epithelial type cancers. So we're going to move on to our germ cell tumours. Range of tumours, they're overall approximately 20% of the spread between the different histological types, predominantly happen in younger patients. Okay, age withheld, clinical information not provided, but nonetheless, this is a very typical example of a lesion which is, so it's multilocular solid, because here we've got septation and here we've got a solid component, but immediately we see this echogenic area with acoustic shadowing. There's some we can see vascularity externally, but none within the tumour. And coming through, this is a beautiful, beautiful example, a very clear-cut picture. This is probably my favourite case of the tumour type, This is obviously a dermoid tumour. And our stratification systems agree that in this sort of case, we don't need to be applying iota systems or so on. We've got a benign descriptor. It is a unilocular tumour with mixed echogenicity and acoustic shadows, and we can diagnose it fairly confidently. But just to make the point that, as I said, that was an excellent example of a very beautifully presented dermoid cyst, and that is not always the case. So sometimes it's really hard to work out what's going on. That's just a reality of things. So if you look at the ultrasound images on this case, I'm looking at something cystic here. I think it's the bladder over here. But it's very hard to see, is this part of a tumour that is shadowing, or is this bowel adjacent to some fluid? So far more difficult to be definitive on something like this. So just because this is a dermoid cyst, and I'm giving away the fact that it is a dermoid cyst, but just because it is a dermoid cyst doesn't mean that you'll always have that clear-cut spot diagnosis. So there are cases where you can sort of step away from any system and realistically say, look, this case, it's just too hard to assess with confidence. We need to do something else. And in cases like this, often we do go to MRI, and of course, although this is predominantly an ultrasound based talk, this is MRI of the same lesion, and straight away everything is so much more straightforward. So we see there's obviously a definite mass, and it's lying, here's our bladder, there's the uterus all squashed up here, and this mass is sitting right behind the uterus, and it's got various different components. It's got this T2 hyperintense homogeneous component here. It's got another component which looks T2 hyperintense, but not quite the same. It looks a bit dirty. Maybe there's a few really thin septations in it, and there's some other tissue around it. Looking at the same picture in axial planes, that's our sort of homogeneous component. And the somewhat dirty septated bit next to it. As we scroll through, we see a few follicles around this, so this confirms to us that this is of ovarian location. And on the T1, our homogeneous component is of low signals, confirms this is simple fluid, and we've got T1 bright component here. And of course, whenever we see T1 areas in a lesion, in an adnexal lesion on MRI, one way or another, it's got to be a home run. You can work it out. And in this case, it's fat saturating. So this is a clear fat component in a dermoid cyst. Moving right along. Next case, a young patient, 12-year-old, acute pelvic pain. So 8 centimeters by 6.8, large, multilocular lesion with solid components. So multilocular solid. With some of these components, it was somewhat debatable, difficult to decide whether this is really a papillary projection, or is this something that's floating within the cyst? It doesn't have any internal vascularity. It's got sort of sharp margins around it, at least on this view. But some of them certainly do seem quite well placed on the septa. So these, even though they're vascular, these are certainly solid components. So multilocular solid tumour without much internal vascularity in a 12-year-old girl. So this is really hard. I mean, there's no way we can tell what it is. And it makes it harder, of course. The risk proportions are different in a child compared to an adult. But, the sense is that it's going to need to come out. And, of course, in a pediatric population, germ cell tumours are more common, and they can have very variable appearances. when we apply our system, so according to IOTA simple rules, IOTA is sort of a bit clueless, just like we are about this. So it says it's inconclusive. The ADNEX model, so it was a 12-year-old patient, but the ADNEX model doesn't go down to 12. So I've put in 14, and 14-year-old will have really the same risks as a 12-year-old. So 9 centimeter lesion with a maximal one of those papillary projections measured 2.5 centimeters. Yes, more than 10 locules. There's lots of small loculations around there. 3 papillary projections, no acoustic shadows, and no ascites. So what we get is we've got reasonably high risk of malignancy, right? And most of it is thought to be considered as borderline risk, but 55% overall risk of malignancy. And according to ORADS, it's an intermediate risk for malignancy, which also recommends essentially management by a gynae oncologist. And so this is a struma ovari, which is a fairly rare subtype of the teratoma tumours, which has got a large component, predominant component of thyroid tissue. Just as a little bit of a side point, or perhaps for geek points or for path exam, maybe, really just out of interest. Whilst it's hard to be definitive about the diagnosis in a tumour like this, there is some literature that's described, and I've got a reference down below, and it's a very good set of papers of a specific appearance in struma ovari tumours named struma pearls, which are well circumscribed roundish areas of solid tissue which do represent thyroid tissue. And just in retrospect, I think there's a couple of areas in there that might just come under that category of struma pearls. Another case of a young patient, 14-year-old, presenting with abdominal distension, and we've got some tumour markers there. So she's actually got an elevated CA125 and a mildly elevated beta-HCG. Solid tumour, large, okay, 16.5 centimetres in diameter in the midline. And just coming back to that colour picture, so very vascular, lobulated, irregular solid tumour. This is concerning regardless of age or anything else, but in fact this patient had a CT scan as well, and we see that firstly we've got the very large tumour occupying a large part of the central abdomen arising from the adnexa, but also she's got some para-aortic lymphadenopathy. So having the benefit of multimodality imaging, it even further, of course, increases our suspicion that this is a malignant tumour. And IOTA simple rules, it's got 2 M features. It's an irregular solid tumour, and it's got very strong blood flow. It's got no B features, so IOTA is also worried. ADNEX model, so with the lesion details of this tumour, ADNEX is very worried. It gives it a 52% risk of malignancy, and it's erring towards the even more of the higher grade tumours. And ORADS is also very worried, category 5. So this is a dysgerminoma, which is a malignant tumour. So we're all, I think, both our general opinion and all the stratification models were in agreement that this is concerning. And the only, again, extra point just for interest or, did I say geek points or something, is when you actually look at the stromal appearance of this lesion, take note of these echogenic bands that extend between what appears to be separate lobulations. So it's got a lobulated contour, and it's also got an internal lobulated appearance. It almost looks like a cirrhotic liver. And this is what the tumours look like histologically as well. So they've got these multiple lobulations with bands of tissue between them. So that's actually, whilst not enough to state the diagnosis confidently on imaging alone, but it's something perhaps to look for in tumours in younger patients. It's a appearance that's been associated specifically with dysgerminomas. Okay, and moving on from germ cell tumours to six-called stromal tumours. So there are more types than these, but these are perhaps the main ones: fibroma, thecoma, granulosa, and Sertoli-Leydig. Fibromas are the most common, and pure fibromas are not hormonally active, but often you'll have combinations of fibrothecomas as well. Thecoma and granulosa tumours both secrete estrogen. And therefore they will be associated potentially with endometrial thickening. So another reminder, we talked about that with the endometrioid, but another reminder with thecoma and granulosa cell tumours, that they can be associated with endometrial abnormalities. And to put the backwards spin on that is, if in an exam setting you're given a case which has got a mass and endometrial thickening and you're asked for a differential, you would then say that in the setting of endometrial thickening, some of the tumours that may be associated are the endometrioid, thecoma, and granulosa cell tumours. Sertoli component of Sertoli-Leydig are also estrogen producing, but just very, very rare. And the Leydig tumours so Leydig cells are the androgen producing. So just again to keep in mind in a patient presenting with virilization type presentation. Okay, so before we start diagnosing this area, please note that this is actually uterus, so we're still looking at uterus pictures, but we've got a mass with calcification and acoustic shadowing, and then we've got another one here. So we're actually starting off by looking at a multifibroid uterus. There's another appearance, and there's another fibroid which is echogenic. So coming through, right ovary looking normal, and in the left ovary we have a lesion which, just take note how similar it looks to the uterine fibroids. So a very typical just gestalt kind of feeling for a fibroma, and I'm just going to take it all, because this is quite an obvious appearance. I'm not going to do too much guesswork with this case. Fibromas look like fibroids. Okay, fibromas are typically small, well-circumscribed masses with acoustic shadowing, and when we see an adnexal mass which is small, solid, and it has acoustic shadowing, and it's regular, and it's got no internal vascularity, we are very glad, because we can be quite reassuring. We still would send this patient to a gynecologist generally for review. They will still need monitoring, and certainly if the lesion grows on monitoring, it would need to come out. But a lot of the time these tumours can be observed and spare the patients surgery through lack of definitive diagnosis or definitive opinion. According to IOTA simple rules, both the shadowing and absence of vascularity are benign features. It has no M features. The adnex model, 60-year-old patient with a solid mass and none of these other things, and acoustic shadows present, 97% chance of benign tumour, despite patient being in a postmenopausal group. So you can see how much they really value, I think, this acoustic shadowing thing. It was also small. And ORAD's also low risk of malignancy, 1 to 10%, management by gynecologists, which is what we had already discussed from our clinical opinion as well. So a diagnosis of probable fibroma, probable because this tumour was never excised, and it was followed up and it was stable. Okay, next case, we haven't got any clinical information given, but this is a premenopausal patient. Right adnexal mass. So this lesion is predominantly solid. It's got a few cystic components to it, but not a lot. So it's certainly less than 80%. So we call this a solid mass. Just trying to find some color pictures. They're mostly on the transabdominal, I think, images. So there is some color. It's not color score 4, so it's not extremely colorful. Not what I want to say. It's not that marked vascularity, but nonetheless a solid mass in the adnexa. Not much else to say. We're certainly concerned. We want to. We think that this is likely to be malignant. IOTA simple rules 1M feature irregular solid tumour. So IOTA agrees it's a malignant lesion. Adnex score, so 79 millimeter lesion, which is essentially solid, no locules, no papillary projections, no acoustic shadows, no ascites, gives it a 40% chance of malignancy, but note that not borderline. If it's malignant, it's potentially high grade. 40% is certainly, whilst you could say, well, it's saying more than 50% chance of benign tumour, but nonetheless, our cutoff will be somewhere between 10 and 20% for surgical excision. So still very much within that zone where we would recommend surgery. And ORADs, category 5, high risk of malignancy, management by a gynae oncologist. So that's a typo, and there's 2 typos there. That should both have been changed. So management by a gynae oncologist, category 5 lesion. And this was a granulosa cell tumour, right? So we're within that sex called stromal area. Not too much particular about this tumour. There is, again, just as we were talking about with a couple of the other tumour types, when are there these little things that we can latch onto that hedge us towards one way or another? I mean, firstly, I hope I've made it fairly clear that the specific histological subtype is less important at this stage than making the assessment of, is this malignant and needing to come out, or can this be watched, or is this likely to resolve on its own? So in this setting, nothing in this case too particular, but just again out of interest, there is sort of this feature of granulosa cell tumours being called having Swiss cheese, so that the typical granulosa cell tumour appearance is a solid mass with lots and lots of cystic spaces throughout. Not that you'd make a call on that, and that once I start putting pictures of cheese on my slides, I'm desperately trying to hold on to attention of whoever's left with me. And with that, I'm moving on to the last case. So this was also a premenopausal patient. I believe she was 40 years old. And first couple of images here, uterus with lots of fluid around it and a very irregular mass with lots of cystic spaces. I mean, just on the first picture, this is badness, right? There's something bad going on here. We've got ascites and we've got a big angry looking tumour here. So again, lots of ascites. So this is either, depending on how you want to call it, this is either a solid tumour, this is a multilocular solid tumour. It doesn't really matter. It looks terrible. It's very, very vascular. It's got ascites. And in fact, we do have the CT available as well. There's a few potentially liver lesions which we can't quite characterise on this scan alone, where you can see the ascites. She's also got bilateral pleural effusions. Just checking, she's got some prominent lymph nodes as well, lymphadenopathy. So it's lots and lots of concerning features, and also just coming through. So there's just to give you a better idea of the size of the mass. And probably just coming back to this series as well. Subtle amongst everything else going on, but here's actually a segment of sigmoid colon which has got generalized mural thickening. So we're concerned, full stop, and we're also concerned that this may be secondary. IOTA simple rules gives us 3 M features. IOTA adnex model gives us 96% chance of malignancy with higher grade tumour, either higher grade tumour or metastasis favoured. And ORADS is also in agreement, and this was metastasis to ovary from the gastrointestinal tract from bowel. So I think these cases show that we've got fairly good correlation in most cases. And I think it's somewhat reassuring that the risk stratification models are generally in agreement with what we would have thought anyway. And often it's helpful to use one of these, I think, as I tend to make up my mind first and then turn to something to help me just for reassurance, or perhaps to reconsider if it doesn't agree with me. So in summary, I really suggest and advise the use of standardized and discriminatory terminology. It helps people understand what you're reporting, and it helps you apply your reports to stratification models if you wish to use them in conjunction with your reporting. Do try and indicate your risk and your opinion where possible, and do try and suggest sensible management and follow-up where possible. And thank you for listening. Thank you for sticking with us so far. I hope you are enjoying the session. And before we finish things up, I'm going to take you through a couple of live cases that draw on some of the themes that we explored today in the lectures. So the first of the cases should be below this video on your screen now. And this is a case of a 15-year-old girl who was referred for recurrent abdominal pain. And she's had a previous ultrasound that showed a cystic mass, and she's coming in now for further evaluation with MRI. So I'll give you a couple of minutes to look through those cases. Feel free to comment in the chat, and then I'll come back a little bit later and we'll discuss the case together. Okay, so let's go through this case together. So in general, I prefer to start looking at gynecological MRI with a sagittal series. So I find that it helps me get a better overview of what's going on in the image. So if we find the midline and go from there, there's approximately the midline here with the bladder urethra. And the first thing I want to do is locate the uterus and characterize it. So I have seen the uterus on this image coming through it, but actually it wasn't in the midline. It was all the way out onto the side here. So that's our normal uterine appearance there. And I've had to come a fair few slices to get there. But here it is, normal anteverted appearance with the high T2 signal endometrium. And it's somewhat small, but she's 15 years old, so that's not out of keeping for me as such. There's the adjacent ovary, so we're actually over onto the right side. So there's the right ovary, which has got a couple of smaller follicles and a slightly larger cystic component, which isn't quite as bright on T2 as the follicles, and we might just come back to that a little bit later. But we've identified those structures, but of course, right in the midline, not to ignore the sort of elephant in the room, is this really large mass, which is of predominantly low T2 signal. And so what we're going to do is skip over to another plane to look at that further. So we'll come over here onto the axial plane now, and now we are switched over from T2 to T1 imaging. So here we've got this mass which arises fairly low down in the pelvis, and there are two things about it that are quite striking. So first is the signal. So it is T1 bright, so already we're thinking right, hemorrhagic. Now the other thing that's interesting about it is its shape. So it's got this sort of double-barreled elongated appearance. It's sort of almost a double bubble kind of thing, but I don't think that term is supposed to apply to pelvic lesions, but it's got this lower component which has got a slightly thinner wall. Then we come to the middle, it's got something of a waist, and then we go further up top and it continues on with a slightly thicker wall. So if you haven't put your thoughts down as to what you think this component is yet, please do so now before I say what I think. So this is a fairly typical appearance of a hematometrocolpos. So this is blood within the vaginal cavity, continuing on through the cervix and to the uterine cavity. And generally what we see if we've got obstruction to outflow of menstruation, which occurs low in the pelvis and the vagina. So we've got an obstructed vagina and blood-filled vagina, uterus, and here, continuing on through this serpiginous structure, we've also got a hematosalpinx on the same side. Now, hematometrocolpos I say, but we've already identified the uterus, right? So obviously we are continuing on from Emmeline's theme of Mullerian duct anomalies, and what we've got here is a didelphys uterus where one half is unobstructed and then the left side is obstructed. Now this is a particular sort of syndromic appearance, and there's one more component of it that will clinch the diagnosis for us, and hopefully you've identified one other finding on this scan, and we see it really on this coronal image coming through here. And you hopefully will have noticed that we've got absence of the left kidney. So we've got unilateral left renal agenesis with a hypertrophied contralateral kidney. So this constellation of findings of a didelphys uterus with a transverse vaginal septum causing a hematometrocolpos associated with unilateral renal abnormality, which in most cases is a unilateral renal agenesis, is a syndrome which has got two names. One of them is an acronym and one of them is an eponymous name. So the acronym is OVIRA, so it's OHVIRA, which stands for obstructed hemivagina ipsilateral renal anomaly, which is what we just said it was. And then the eponymous name for it is this triple-barreled Herrmann-Werner-Wunderlich syndrome. So pick one or the other, but it is a fairly pathognomonic appearance. And just one other thing to come back to, of course, we saw in the ovary, this is completely unrelated to this syndrome, but since we're here, just to revisit this right ovary where we saw a cystic lesion on the T2 imaging, which this is the fat saturated T2, and then it was also bright on T1, so that's hemorrhagic. And this just draws back, whilst most of this case relates to Emmeline's case, this draws back to Natalie's presentation and the discussion of T1 bright masses. Can we tell whether something's as an endometrioma or hemorrhagic cyst? To my eye, this could be either in this case, but in a 15-year-old girl with this sort of appearance, and no other features of endometriosis anywhere else, I would suspect this is probably going to be a hemorrhagic cyst. I don't think it's actually related to the rest of her findings, and this would be followed up with ultrasound just to see whether it's resolving or not. So if it resolves, it confirms that it'll be a hemorrhagic cyst. So that's case number 1. Now moving on to case number 2. The case number 2 will be appearing on your screen below, and it's a 40-year-old female with chronic pelvic pain and abnormal vaginal bleeding. So again, I'll give you a little bit of time to look through this case and then we'll go through it again. Okay, ready to review this case. Now, if with the first case that we looked at, you saw a T1 bright lesion and expected that we were going to be talking about endometriosis, well, sorry, we weren't, but here we are. So, and I'm telling you this from the outset because there's enough in this case to go through in terms of just characterizing the disease without having to talk about the diagnosis. So this is endometriosis. Now let's look at it. Again, as with the previous case, I tend to start with the mid-sagittal view on the T2 acquisition. And so on this image here, on these couple of images centrally, the first thing that strikes me is the appearance of the uterus. So we've got here a uterus which is anteverted. Here's the cervix coming forward through the uterine body. And there's the endometrium at a slightly curved, so there is a slight degree of retroflexion. So anteversion with a little bit of retroflexion. And here we can see the zonal anatomy of the uterus, and that's the junctional zone anteriorly there. And there it is here. It's fuzzy and sort of thickened and irregular. And even without measuring it, this to me has the appearance of adenomyosis involving the posterior wall. In general, looking at gynecological imaging, if I see a uterus which is anteverted, retroflexed with posterior wall adenomyosis on either ultrasound or MRI, even without seeing anything else, I'm thinking there might be endometriosis. So adenomyosis isn't specifically a part of endometriosis, but they do often go together. So that's the first thing. Now, the next thing that I'm seeing in this scan that really strikes me is this appearance here. So, and this is part of what Natalie was talking about, this location at the posterior midline aspect of the uterus, just at the level of the cervix internal os, and this is the torus uterinus. And we can see here low signal dense adhesion between the torus uterinus, an area of thickening of rectal wall. So I'm wondering whether there might be actually a rectal nodule there, but at the very least there is adhesion across the pouch of Douglas. Now when we come out to the side, so we've got this T2 bright lesion which has got a few follicles around it, so suggesting to me that this is within the ovary. And we can see a line coming through here. So we've got a fluid level in there. And then coming over across to the other side, we've got also a lesion which has got some stroma around it and some follicles, so again suggesting it is within the ovary. It is of lower T2 signaling on the other side and also appears to have a smaller fluid level. Coming through both of these, see how we saw this adhesion between the rectal wall and the torus uterinus? Right adjacent to it, as we come to the side, both ovaries actually appear to be stuck down as well. So again, this low signal dense adhesions on one side and on the other. So that's a very typical appearance with deep infiltrating endometriosis. And so coming over to an axial plane now, coming through these images, here we've got that fluid level that we saw before, one side, little one on the other side. And right here, we've got this sort of central node of adhesion that everything seemed to be pulling into. So the ovaries may not be sort of kissing ovaries as such because they're not kind of touching each other, but they're certainly both clutching onto the uterus very tightly. Here's the T1 weighted scan confirming what we suspected, that both of these lesions are bright on T1. In my practice, I would always have a T1 fat saturated image here just to confirm that, and also look for any smaller T1 bright lesions which are at a fat interface that we might not be seeing on this image. Okay, so that second case was a case of deep infiltrating endometriosis associated with posterior uterine wall adenomyosis. So hopefully you found those cases helpful as a refresher and an adjunct to Emmeline's and Natalie's talks. And thank you again for joining me in this session. And of course, thank you to Natalie and Emmeline for their wonderful talks, and to our sponsor Foxo. Now, the next session starting here very soon is an advanced abdominal imaging session which is hosted by Natalie Yang and features lectures by Mark Goodwin, Pierre Abdul Ahad Aziz and Vikas Shah. So hopefully you can stick around for that, and I'll be back a little bit later on to present my talk on ultrasound assessment of the fetal head, and hopefully I'll see you then too. Bye.